For the first time in a full decade, the playbook we use to protect a patient's heart during surgery has been totally rewritten. The ACC and AHA have just dropped their massive 2024 guidelines for non-cardiac surgery. And listen, this is not just a little update. It's a brand new roadmap, and it's going to redefine our standard of care. And just to set the stage, think about this number for a second. 313 million. That's the estimated number of surgeries happening across the globe every single year. The scale is just massive. And every one of those procedures comes with a potential cardiac risk that we, as clinicians, have to manage. So, it all boils down to this one crucial question that really drives everything we're about to talk about. How do we actually protect the heart when the body is under the massive stress of surgery? Well, this 2024 update gives us a much sharper, evidence-based answer. Okay, so here's how we're going to walk through this new roadmap. We'll start with the big picture, the new philosophy. Then we're going to get into the details of a smarter pre-op risk assessment. After that, we'll open up the new medication playbook, tackle the absolutely critical concept of myocardial injury or MENS, and then we'll wrap it all up with the key takeaways you can start using like tomorrow. The core message here is a really fundamental shift. We're moving away from working in silos and toward a patient-centered, team-based approach that's all built on shared decision-making. And this is interesting because it actually brings the US guidelines much more in line with the European ESC guidelines, which have been pushing this collaborative model for a while now. All right, let's start where every patient's journey begins, that pre-operative risk assessment. And right away, the new guidelines are telling us we need a more thoughtful approach, one that goes way beyond just ticking off boxes on a simple checklist. And this, right here, is the new framework. It's a really logical, step-by-step process. First things first, you identify and stabilize any active, urgent cardiac problems, like decompensated heart failure. Simple enough. Then, you calculate the risk of a major adverse cardiac event, or MACE. Step 3, you assess their functional capacity. 4, you think about biomarkers. And finally, and this is brand new, you incorporate something called risk modifiers. Now, what's really important here is the huge philosophical shift this represents. This quote gets right to the heart of it. The days of just ordering a routine pre-op stress test on everybody, they're over. The guidelines are crystal clear. Only order a test if the result is actually going to change your plan. Like, will it change the medications or even the type of surgery you're planning? If not, don't do it. So how do we get a better handle on functional capacity? Well, instead of just asking, hey, can you climb 2 flights of stairs? The guidelines are now pushing for structured tools like the Duke Activity Status Index, or DACI. It's just a more objective way to figure out a patient's exercise capacity, and we know that a score over 34 is linked to a lower risk of cardiac problems after surgery. Okay, let's circle back to that new step I mentioned, risk modifiers. This is a totally new concept in the 2024 guidelines. Think of them as crucial clinical red flags that the standard risk calculators just don't account for, but they can dramatically increase a patient's true risk. They add that essential layer of clinical judgment on top of the raw score. And here are some of the big ones to look out for. If your patient has severe aortic stenosis or significant pulmonary hypertension, or is just clinically frail, well, their risk is way higher than a simple score might tell you. Spotting one of these should trigger a deeper conversation, a team huddle, and maybe even a discussion about advanced monitoring, like a perioperative echo or, in some cases, even a PA catheter. So, this much better risk assessment flows directly into our next big decision point: what to do with medications. And the new guidelines give us a much, much clearer playbook for managing those critical cardiac drugs right around the time of surgery. This is one of the most practical updates, for sure. We now have really specific timelines for how long to wait for elective surgery after someone gets a stent. And notice the key difference. For a drug-eluting stent put in for stable angina, you want to wait 6 months, but you can consider surgery after 3 if you really have to. But, and this is a big but, if that stent was for a heart attack, the ideal delay is a full year. It's all about that delicate balance between the risk of the stent clotting off and the urgency of the surgery. The great debate over holding or continuing meds like ACE inhibitors and ARBs has been going on forever. The new guidelines basically acknowledge both sides of the coin. Yeah, holding them can definitely reduce low blood pressure during the operation, but continuing them is now seen as totally reasonable for a lot of patients, and it's probably the right call for those with heart failure with reduced ejection fraction. The bottom line, it's not a blanket rule anymore. It's an individualized, patient-by-patient decision. Now, here is one that is not up for debate. The guidelines give a new, very clear recommendation for SGLT2 inhibitors. They need to be stopped 3 to 4 days before surgery. Period. This is a critical safety move to cut down the risk of euglycemic DKA, which is a really serious complication we want to avoid. Okay, let's get to one of the absolute biggest updates in these guidelines: the formal recognition and management plan for myocardial injury after non-cardiac surgery, or MINS. This is a huge step, bringing the U.S. approach much closer to what our Canadian and European colleagues have been emphasizing for years. It officially defines MINS as its own distinct problem that we need to be actively looking for.
So what is MINS? It's any elevated troponin after surgery that we think is from an ischemic cause. And here's the kicker. This includes troponin bumps in patients who have zero symptoms. Even a small, silent rise in troponin is a powerful, powerful predictor of 30-day mortality. We just can't afford to miss it anymore.
So if we have to find it, how do we do it? The guidelines now recommend postoperative troponin surveillance for our at-risk patients. So we're talking about anyone with known heart disease or patients over 65 with risk factors who are having a higher risk surgery. And the protocol is simple. Check a troponin at 24 hours and then check it again at 48 hours after the operation. And if you find one, if the lab calls with a high troponin, this is your game plan. That lab value triggers a clinical evaluation. Does the patient have any symptoms? What does the EKG look like? This helps you figure out if you're dealing with a type 1 MI, a type 2 MI, or something else entirely. But no matter the cause, any elevation means it's time to get the team involved to optimize their care and their follow-up plan.
Wow, we have covered a ton of ground. So let's take a breath and boil this all down to the most important, practice-changing shifts that really define the new standard of care. If you walk away with nothing else, please remember these 4 things. 1. Adopt that stepwise, team-based approach to risk, and don't forget about those new concepts like risk modifiers and frailty. 2. Use stress tests sparingly. Ask yourself, will this change what I do? 3. Know the new medication rules, especially that hard stop on SGLT2 inhibitors. And 4. Start systematically screening for MINS with troponins in your at-risk patients. It's the new standard. You know, the 2024 guidelines are really more than just a list of do's and don'ts. They're a call to action for a more collaborative, more thoughtful culture in perioperative medicine. And so that brings us to the final question we all need to be asking ourselves. In our own hospitals and our own clinics, are we really prepared to make this kind of integrated, team-based care the new default for every single patient who comes through our doors?